Welcome back to the Deep Dive. Today we are taking on a challenge that sits right at the very core of orthopedic and, well, neurosurgical practice. We're talking about the spine.
We are. And it's arguably the most mechanically complex and, clinically demanding area in the entire human body.
It truly is. So we're going to be doing a deep dive into Chapter 37, which is titled The Spine, from the 28th edition of Baily and Love's Operative Surgery.
And for anyone in training listening to this, you'll know this chapter is just monumental. It covers, everything from the most sort of mundane backache all the way to conditions that need immediate life-saving surgery.
Right. And our mission today is very focused. We are explicitly not here to just read the textbook back to you.
That would be incredibly tedious.
And frankly, not very helpful.
Yeah.
Instead, what we're trying to do is interpret it, synthesize it, and most importantly, give you a kind of high-yield conceptual map. So if you're a medical student prepping for exams, or a junior doctor on rotation, or even a specialist trainee who needs that rapid recall, think of this as your ultimate ready reckoner.
Exactly. We're drilling down into the critical thresholds, the key stats, and the core mechanisms that you absolutely have to understand, not just memorize.
And that focus on understanding, that's the key, isn't it?
It is. We're going beyond the what and really trying to get into the why behind the decisions. Why is this measurement so important? Why is the timing on this so critical? Our aim is to structure this knowledge so you can apply it, right away in the clinic. And hopefully you can use this chat as a guide to deepen your own reading of the original text.
Okay, so let's unpack this. And I think we have to start by grounding ourselves in the sheer scale of the problem. Because the numbers themselves, they give us our first crucial clinical markers.
Yeah, let's do it. When we talk about low back pain, we're talking about a near universal human experience.
Yeah.
The stats here are, they're staggering.
So hit us with a number. What are we looking at?
Low back pain, or LBP, has a lifetime prevalence of somewhere between 60 and 80%.
Wow.
Yeah. That means 4 out of 5 people listening right now will, at some point, have a pretty significant bout of low back pain. It is the leading cause of years lived with disability, period. Worldwide.
That puts it into perspective immediately.
Right.
But the real skill for a clinician is separating that vast majority, the mechanical self-limiting aches, from the really serious stuff.
That's the first fork in the road.
So what's the key contrast we need to anchor?
The contrast is between that general LBP and true sciatica. So true sciatica, that's radicular pain shooting down the leg from actual nerve root compression. It's much, much rarer.
Okay.
Its lifetime prevalence is only about 2 to 4%. So when you see a patient, that immediate distinction, is this axial muscular nonspecific pain, or is it true radicular pain that is vital for triage?
So if 80% of us are going to get low back pain, how long should we expect it to last before we really start to worry? This must be a critical point for counseling patients.
It is, and this is the good news. It's a statistic you should absolutely keep in your back pocket for reassurance. The vast majority of acute LBP, we're talking about 90%.
90%.
90. It's self-limiting, it resolves, and the patient can get back to work or normal activity within just 6 weeks.
6 weeks. That's a really powerful benchmark, isn't it?
It is, because if a patient is still suffering and restricted past that 6-week mark, that's when the alarm bells should start ringing a bit louder. It forces you to reevaluate.
And what about true sciatica, the nerve root problem? Does that take longer to settle down?
It does take longer, but the prognosis is still pretty favorable, even for acute sciatic episodes, caused by a small disc herniation. Up to 70% of those will settle on their own within 3 months.
So the body can actually resorb that disc material?
In many cases, yes. That 3-month window allows time for the body to do its work, for inflammation to go down, and for conservative treatments like physio and NSAIDs to really kick in.
Okay, so the immediate takeaway from the epidemiology is clear then. LBP is super common, overwhelmingly resolves within 6 weeks. True sciatica is less common, but still has a high resolution rate within 3 months.
Exactly. And that conservative expectation should guide your initial management, unless, of course, you see those infamous red flags, which I'm sure we'll get to.
Absolutely.
Yeah.
So to understand what goes wrong, we need to understand the ideal state. Let's talk about alignment and anatomy.
Right. And I want you to visualize the spine not as a straight pole, but as a perfectly balanced, let's call it an energy-efficient tower.
I like that.
It's designed with these specific curves, a kyphosis and a lordosis, that minimize the energy you need just to stand upright. Any deviation from that, And your muscles have to constantly fire, which leads to fatigue and pain.
Okay, let's lock in those measurements for normal sagittal balance. This has got to be crucial for any kind of pre-op planning.
It is. So starting from the top, your normal cervical lordosis, that's the curve in your neck, should be between 35 and 45 degrees. Moving down, the thoracic kyphosis, that gentle backward curve in your upper back, that's normally about 20 to 50 degrees. Average is around 35.
And then the big one, the lumbar lordosis.
The big one. It's the most critical compensatory curve. And it's got a really wide range, somewhere between 40 and 80 degrees, with the average being about 60.
And what's important about where that lumbar curve is concentrated?
That's the key. That 60 degrees isn't spread out evenly. The vast majority of that lordosis happens very low down, specifically between L4 and S1.
So that's the pivot point.
That is the pivot point of the body. And that massive concentration of curve and movement is exactly why the L45 and L5S1 discs are the highest stress areas and, the most common sites for degenerative disease.
So if the spine is our energy efficient tower, what's the sagittal plumb line?
The plumb line is your vertical standard. It's the perfect center line. So when a patient is standing, an imaginary vertical line dropped from the center of gravity should fall from the odontoid process at C2, run through or very near the C7-T1 disc space, cross the column around T12-L1, and land squarely on the posterior superior corner of S1.
And if it doesn't?
If the patient is pitched forward, we call that positive sagittal balance, or backward, that immediately flags a mechanical problem. Their muscles are fighting gravity all day long, and that often leads to chronic pain.
Okay, let's move inside now from the bony column to the nervous tissue. We have to anchor the spinal cord's termination point. This is just fundamental.
It's the definitive safety checkpoint. The spinal cord itself terminates behind the body of L1. L1 is the textbook safe anchor. Sometimes it's L2, very rarely L3. Below that point, you just have that collection of floating nerve roots, the cauda equina.
Which is exactly why a lumbar puncture is safe below L2.
Precisely. Usually at L34 or L45. And it also defines the type of injury you're dealing with. Compression above L1, L2 causes myelopathy, that's a spinal cord injury, UMN signs. Whereas compression below L1, L2 causes radiculopathy or cauda equina syndrome, that's a nerve root injury, LMN signs. Knowing L1 is the cutoff just simplifies your whole neurological framework.
Okay, let's talk blood supply. This is where it gets really critical for surgery, especially anterior approaches. We need to focus on this vascular lifeline, the artery of Adamkiewicz.
Yes, named after the Polish pathologist. This one vessel is the sole major supply to the lower two-thirds of the spinal cord. If you accidentally ligate this artery,
the result is catastrophic.
Potentially, yes. Critical spinal cord ischemia, paraplegia. It's a huge risk.
So what are the two pivotal anatomical details about this artery that every surgeon just has to know?
The first is a location marker. It's found on the left side in about 80% of people.
Okay, that's helpful.
It is. And more importantly, it usually enters the spine with a ventral nerve root, typically somewhere between T9 and T11. But, and this is a big but, it's an anomaly. It can enter anywhere from T5 down to L5.
That variation is what makes it so dangerous. So for a surgeon doing an anterior approach and they have to ligate segmental vessels, what's the specific safety measure the text highlights?
The surgical technique marker is to ligate the segmental vessels only over the midpoint of the vertebral body.
Why there specifically?
You do that because the radicular artery, which is carrying that crucial blood supply, enters the canal through the intervertebral foramen, which is right next to the disc space. By ligating at the vertebral body's midpoint, you're as far away from that foramen as possible.
You're maximizing your distance from the danger zone.
Exactly. It is a game of millimeters.
Okay, so let's move on to the clinical process.
Yeah.
Spinal assessment is, what, 80% history?
At least. It's 80% history and 20% everything else.
So beyond the standard pain description site, type, severity, what do we need to be intensely focused on to filter out the benign stuff from the potentially catastrophic?
You have to be laser focused on identifying serious non-mechanical pathology. So mechanical pain is predictable, right? It's worse with activity, better with rest. Non-mechanical pain is the opposite. And therefore, the single most powerful question you can ask is about night pain.
Okay.
You ask, is the pain relieved by lying down or changing position? If the patient says they're woken from sleep by pain that does not get better when they move around, that is a massive alarm bell. It suggests tumor, infection, or severe inflammation.
And that moves us right into the systemic red flags. These are the symptoms that demand an immediate, thorough investigation.
Absolutely. The systemic alarms are your constitutional symptoms. Unexplained weight loss, more than 10 pounds in a short time. Chills, fever. And crucially, you have to dig into their past medical history for any malignancy.
And we need to anchor those key metastatic sources.
Yes. The cancers most likely to go to the spine are breast, lung, prostate, renal, and thyroid. You have to commit that list to memory. It directs everything you do next.
And that's often linked to Batson's venous plexus, that valveless network, right?
Exactly. A patient with prostate cancer strains, and they can inadvertently seed the spine. It explains the pathway. But there's an even more urgent set of questions. The 3 non-negotiables. The cauda equina questions.
This is the true surgical emergency.
It is. If you miss this in the history, you are negligent.
So what are the 3 elements that have to be asked in every single new or worsening case of back or leg pain?
First, you always ask about perineal or perineal numbness, what we call saddle anesthesia. Have you lost sensation when you wipe yourself? Second, you have to ask about bladder function. Difficulty starting, feeling of incomplete emptying, loss of the sensation of fullness, retention, overflow.
All of it.
All of it. And thirdly, the exact same thorough questioning for bowel function, specifically difficulty evacuating or any incontinence. These questions are absolutely mandatory.
Okay, let's pause here. Let's do a quick conceptual check-in question for everyone listening to integrate those red flags.
Good idea. So imagine a patient, let's call him Mr. G, a 55-year-old former construction worker. He tells you he's had on and off low back pain for over a year, always blamed it on old injuries. But recently, the pain has drastically changed. He now reports night pain that wakes him up, and it's only marginally relieved by moving around. He also mentions he's dropped a pant size and thinks he's lost about 10 pounds in the last 2 months, but he just thought he was eating better.
Okay.
What specific red flag category must you investigate immediately based on that change in pain and those systemic symptoms?
And the answer there has to be cancer or tumor. It's the unremitting night pain and the unexplained weight loss. That overrides the entire previous seemingly benign history. If you didn't immediately jump to malignancy, rewind and anchor that list of red flags.
It's the change in the nature of the pain. That's the vital clue.
Okay, moving to the physical exam. We start with simple inspection.
We do. We check posture both front on and from the side, just looking for any asymmetry.
And for scoliosis, we're checking shoulder height, waist asymmetry, but we need a dynamic test, right?
That's the Adams forward bend test. As the patient bends forward, if there's a true structural scoliosis, you'll see the rib cage or the loin prominence become much more obvious on one side.
And that prominence is key because...
Because it reveals the underlying rotational element of the scoliosis.
And
And that's what defines a true structural curve that might need more aggressive management.
Okay, and for assessing mobility, we need a quick, reliable measure. That's the Schober's test.
Schober's is fantastic. It's so simple. You measure 10 centimeters up and 5 centimeters down from the posterior superior iliac spines. That gives you a 15-centimeter span. Then you just ask the patient to bend forward as far as they can.
And what's a normal result? What are we looking for?
A normal increase in that distance should be at least 5 centimeters. So the final measurement should be 20 centimeters or more.
And if it's less, what's the clinical significance?
If it increases by, say, only 2 or 3 centimeters, that suggests really reduced lumbar mobility. It points towards an inflammatory process, a classic finding in something like ankylosing spondylitis. It's a great screening tool.
Okay, now, for the part that I think is often the hardest to master conceptually, the neurological assessment, UMN versus LMN.
Right, and let's use our metaphor. An upper motor neuron lesion is like a circuit breaker stuck on. A lower motor neuron lesion is like a worn wire that's broken.
So why is the circuit breaker stuck on?
Well, the UMN tracts, they come from the brain down the spinal cord, and they have an inhibitory or regulatory effect on the peripheral nerves. When the UMN is damaged, say by cord compression, that inhibitory control is lost.
So when that circuit breaker is on end, what do we see?
You see an excess of signal. So you get increased tone spasticity, you get exaggerated deep tendon reflexes, hyperreflexia, and critically, you get the pathological reflexes. A positive Babinski sign, an upgoing toe, and often ankle or patellar clonus. It's a totally overactive system.
And conversely, the LMN lesion, the worn wire, that means the signal is just broken. It never reaches the muscle.
Correct. So you see the opposite. Decreased tone or flaccid paralysis. You get diminished or absent reflexes, hyperflexia. And because the muscle is totally disconnected, you see rapid, severe muscle atrophy over time, and sometimes those little twitches, denervation, fasciculations.
Okay, to make this useful, we have to rapidly recall the segmental innervation. Let's lock in the high-yield checkpoints.
Let's do it. In the arm. C5 is shoulder abduction, deltoid, and the biceps reflex. C6 is wrist extension and the brachioradialis reflex. C7 is elbow extension, triceps, and the triceps reflex.
And T1?
T1 is the hand intrinsics. A deficit there with UMN signs below is the absolute classic sign of cervical myelopathy.
And for the lower limb?
L3 and L4 are the patellar reflex. L4 is key for ankle dorsiflexion, being able to clear your foot when you walk. L5 is the great toe expansion, the EHL, and that's the one that often gets hit by disc herniations.
And
S1 is the most distal high-yield root. It controls ankle plantar flexion, pushing off when you walk, and the Achilles, or ankle jerk, reflex. If you know these, you can pinpoint the level of the lesion almost instantly.
Let's run a fictional case study right now to apply this.
Okay. Mr. J, a 45-year-old accountant. He reports severe pain shooting down the back of his leg, wrapping around his outer ankle bone and into the side of his foot. On examination, he has a noticeable foot drop and really struggles when you ask him to stand on his toes. When you test his deep tendon reflexes, his Achilles reflex is completely absent, but his patellar reflex is fine, nice and brisk. Which single nerve root is most likely compromised?
And the answer there has to be S1. The combination of that pain distribution along the lateral foot, the S1 dermatome, the weakness in ankle plantar flexion, the S1 myotome, and the absent ankle jerk reflex, the S1 reflex, that is classic S1 radiculopathy.
It is. If you missed that, go back and solidify those segments. That level of precision is just non-negotiable.
Okay, so beyond the basic neuro exam, we have specific tension tests.
Right. And the foundation is the straight leg raise test, the SLR.
You're applying tension to the L5 and S1 nerve roots. It's positive if it reproduces that classic radicular leg pain.
Exactly. But the real clinical nugget here, the highly specific finding, is the crossed SLR test. This is where you lift the unaffected leg, but it causes sciatic pain in the opposite symptomatic leg.
And why is that so specific?
Because lifting the good leg pulls on the dura on that side, which in turn pulls the whole central, the cethecal sac. If there's a big central disc herniation, this action creates tension on the opposite nerve root sheath as well.
Wow.
And the book highlights that the crossed SLR is positive in 97% of patients with a proven herniated disc. If you get a positive crossed SLR, you've pretty much confirmed it.
That's a huge specificity jump. Now, what about the higher lumbar roots, L2, L3, L4?
For those, you do the femoral nerve stretch test. The patient is lying on their front, you extend the hip and then flex the knee. That puts tension on the anterior nerve roots and causes pain down the front of the thigh.
And finally, we have to mention Waddell's non-organic signs.
Yes, and it's not a punitive test. It's a clinical tool to recognize when there might be symptom magnification or other behavioral factors complicating things.
Right.
So you look for things like superficial tenderness to light touch, pain on simulation tests that shouldn't hurt, distraction tests where the pain changes, non-anatomical patterns of weakness or sensory loss, and just general overreaction. Recognizing these helps you pivot treatment towards rehab and psychosocial support instead of just jumping to an unnecessary operation.
Okay, let's talk investigations. And this might be the most valuable part of our discussion for any trainee listening, the imaging dilemma.
It is the single biggest trap in modern spine care. Imaging tests, especially MRI, are incredibly sensitive. They show anatomy in exquisite detail, but, and this is the point, they are fundamentally nonspecific when it comes to linking that anatomy to the patient's pain.
And this is the statistic that everyone needs to have permanently anchored in their brain.
Up to 1/3 of completely asymptomatic patients.
People with no back pain at all.
None. They will have anatomically significant abnormalities on an MRI scan. We're talking disc bulges, annular fissures, you name it.
So you can see the trap. A patient with nonspecific LBP gets an MRI. The scan shows a small disc bulge. And the clinician says, aha, that's the problem.
And they focus on treating that L34 finding, maybe even with surgery, when the patient's actual pain might be entirely muscular or coming from somewhere else entirely. The outcome is a surgically perfect scan, but the patient still hurts. Failed back surgery syndrome.
So the guidance has to be unwavering. All investigations must be carefully correlated with clinical findings.
You treat the patient, not the picture. If the image doesn't match the history and the exam, the image is likely just an incidental finding.
Given that trap, let's review the role of standard imaging, starting with plain radiographs.
You should never order them for routine acute LBP unless you suspect a fracture or there are strong red flags.
But they are essential for assessing things like scoliosis.
Absolutely. Standing films are needed to measure the Cobb angle for scoliosis and to assess global sagittal alignment. But you have to know their limitation, especially for pathology.
Right. What's the threshold for seeing a tumor or infection?
It's severe. You need between 40 and 60% of bone mass to be destroyed before an early tumor or infection is visible on a plain X-ray. By then, it's often quite advanced.
Which is why with red flags, you jump straight to MRI or CT. Speaking of which, CT.
CT is the gold standard for bone anatomy. Fracture detail, subtle pars defects, bony stenosis, it's fantastic for that. But you have the radiation dose penalty.
What are we talking about dose-wise?
A typical lumbar CT is about 5 to 10 millisieverts. To put that in context, that's like 2.5 to 5 years of natural background radiation, so you use it selectively.
And then there's MRI. Beautiful soft tissue detail. No radiation. But what are the key contraindications we have to screen for?
The powerful magnet. So you have to screen for things like certain older pacemakers, specific coronary stents, or intracranial aneurysm clips. Anything ferromagnetic is a potential problem.
Finally, the bone scan. Very sensitive, but where does it fail?
Bone scans are great for detecting areas where bone is reacting rapidly, like in metastases or infections, but they can give you a false negative in certain cancers. The key ones are multiple myeloma and purely lytic metastases, like from renal cell carcinoma, because they are just bone-destroying processes without much of a bone-building reaction.
Okay, so when standard imaging is unclear, we move to more advanced diagnostics, like provocative discography.
Yes, this is the ultimate test to see if a specific abnormal-looking disc is actually the source of the patient's pain. A tiny needle goes into the disc, and a small amount of contrast is injected while the patient is awake.
And what are the two criteria that have to be met for a positive test?
It's all about concordance. First, the injection has to show objective evidence of disc degeneration on the image. And second, and this is more important, the injection must reproduce the patient's usual type of back pain.
Concordant pain.
Exactly. If it just causes pressure or a different kind of pain, that disc is not the pain generator, and surgery on it will fail.
We also use targeted injections diagnostically and therapeutically.
Absolutely. For facet joint pain, you can inject local anesthetic and steroid. If the pain goes away, you found your source. Then you can do a rhizolysis burn the nerve for longer-term relief. Same idea for a foraminal epidural steroid injection for radiculopathy. It confirms the root and treats the inflammation.
And if we suspect infection or cancer, we need tissue.
You do. A spinal biopsy is required, ideally done percutaneously under CT guidance, but sometimes you need an open biopsy.
Okay, let's shift to some specific degenerative conditions, starting with the cervical spine.
Yeah.
Cervical radiculopathy, that's the worn wire problem in the neck.
Right. Nerve root compression causing neck and arm pain, or brachialgia, sensory changes, motor weakness in a specific pattern.
And the management.
It mirrors the lumbar spine. Conservative care, first physio, neuropathic meds. If that fails, then surgery. And the big surgical debate is anterior cervical discectomy and fusion, ACDF, versus cervical total disc replacement, or TDR.
And the TDR is trying to solve the problem that ACDF creates, right?
It is. ACDF fuses two vertebrae, so it eliminates motion. That can put extra stress on the discs above and below, leading to what we call adjacent segment disease.
Yes.
TDR tries to preserve motion at the operative level, theoretically protecting those neighboring discs in the long run.
Now, the much more dangerous condition is cervical myelopathy, the circuit breaker problem, direct spinal cord compression.
Yes. This is the commonest cause of spinal cord dysfunction in patients over 55. And the presentation is this classic mix of UMN and LMN signs.
So break that down for us. Why do you see both at the same time?
Okay, so at the level of the lesion where the cord is being squeezed, the pressure is directly affecting the anterior horn cells. These are the LMN cell bodies for the small muscles at that level. So you get LMN signs atrophy, weakness, often in the intrinsic hand muscles.
And below the lesion?
Below the lesion, the compression is hitting the descending UMN tracts that control the rest of the body. When those are damaged, you lose that inhibition and you get UMN sign spasticity, hyperreflexia, Babinski sign in the legs.
It's a perfect illustration of neuroanatomy. Damage to the cell body versus damage to the long tract.
Exactly. And the treatment is decompression, either from the front or the back, depending on the specifics. And just a quick note for trainees, thoracic disc herniation is extremely rare, less than 2% of all discectomies. If you see mid-back pain, look elsewhere first.
Good tip. Let's go back to the lumbar spine. Lumbar disc herniation, sciatica, affects 2–4% of the population. Over 90% are at L45 or L5S1. But we need to clarify the two types of herniations.
This is the traversing versus exiting root mechanism. It's a classic point of confusion. So let's use the L5 level as our example.
Okay.
The L5 nerve root starts at L5 and has to travel down, traversing the L45 disc space, before it can exit at the L5S1 foramen. So if the disc of protrusion is posterolateral, which is the most common type, it hits that L5 root as it's traversing down.
So an L45 posterolateral disc affects the L5 root.
Correct, the traversing root. But if the protrusion is far lateral or extraforaminal, it happens right at the exit point. A far lateral L45 protrusion will hit the L4 root, which is the exiting root, at that level.
Causing L4 symptoms.
Yes, affecting the knee-jerk and anterior thigh sensation. It's a vital distinction for planning your surgery.
Management is always conservative first, for 6 to 12 weeks. If that fails, microdiscectomy is the standard. Now, what about spinal stenosis?
Spinal stenosis is just age-related narrowing of the canal, and the symptom marker is absolutely definitive, spinal claudication at a walking limit.
Right, the shopping cart sign.
Exactly. Back, buttock, or leg pain that comes on with walking or standing straight, and is classically relieved by a flexed posture, like leaning on a shopping cart. You distinguish it from vascular claudication because that's relieved by just resting, and spinal claudication needs that postural change.
Okay, and then discogenic low back pain.
That's chronic LBP, where you've identified a painful disc as the source, usually after a positive provocative discography. Rehabilitation is mandatory before even thinking about surgery. If that fails, then you might consider a lumbar spinal fusion or, in very select cases, a lumbar disc replacement.
Let's touch on spondylolysis and spondylolisthesis.
Spondylolysis is a defect in the pars interarticularis, that bony bridge, without any forward slippage. It's essentially a stress fracture, very common in young athletes in hyperextension sports.
And the surgery aims to preserve motion.
Ideally, yes. A direct repair, what we call a Buck's fusion, to heal the defect. Fusion is reserved for when that fails or there's already significant degeneration.
And spondylolisthesis is the actual forward slip. We have two key classification systems.
We do. For causation, it's the Wilts classification. Is it dysplastic, ismic, degenerative, etc.? But for planning surgery, it's all about the Meyerding classification, which grades the severity of the slip.
So what are those grades?
Grade 1 is 125% slip. Grade 2 is 26 to 50%. Grade 3 is 51-75%, and grade 4 is 76-100%. And the surgical treatment really hinges on this. For low-grade slips, grade 1 and 2, the treatment of choice is usually fusion in situ. You just stabilize it where it is.
And the high-grade slips?
Much more complex. Often requires extensive surgery, sometimes trying to reduce the slip before you fuse it.
Cool. Let's move into the urgent and severe stuff. Cauda equina syndrome. The true emergency.
We stress the history, now the reality. It's compression of those L4 to S1 nerve roots below the end of the spinal cord. And we have to anchor why these nerve roots are so susceptible to damage.
Okay, what's the mechanism?
It's a vulnerability mechanism. Peripheral nerves have these thick protective layers, epineurium, perineurium. The floating cauda equina roots don't. They have only a very thin sheath, making them incredibly vulnerable to compression and ischemia.
So they damage easily.
Very easily. And the presentation is the classic CES triad. Low back pain or sciatica, the key sign of saddle anesthesia, and the crucial functional loss of variable rectal or urinary symptoms.
And the book gives us this life-saving classification that dictates the urgency, the difference between incomplete CESI and retention, CESR.
This is the definitive ticking clock. CESI, incomplete, means the patient has impaired bladder sensation or difficulty voiding, but they still have executive or voluntary control. They can still go, even if it's hard.
And that requires
immediate MRI and urgent decompression to preserve whatever function is left.
And what defines the more severe CESR?
CESR, retention, means the patient has progressed to bladder retention, often with overflow incontinence. This indicates profound nerve root injury. And while it's still an emergency, the prognosis for full recovery is significantly worse.
And what's the timing anchor?
The surgical decompression outcome is significantly better if it's performed within 24 hours of the onset of loss of bladder or bowel control. If you see a patient with CESI, that 24-hour window starts right now.
Wow. Okay, tumors of the spine.
First thing to anchor, metastatic tumors are overwhelmingly more common than primary spinal tumors, maybe 25 times more frequent.
And we already reinforced the big three primary sources: breast, lung, and prostate.
Right. And the classic radiological sign on a plain X-ray is the winking owl sign. An absent pedicle. It looks like the owl on the AP film is winking at you because a tumor has eaten away one of the pedicles.
That immediately raises the alarm.
It does. But you need a whole spine MRI for full staging, and the surgical threshold is key. Extensive surgery is usually reserved for patients with a life expectancy of more than 3 to 6 months.
And for patients with malignant spinal cord compression?
The evidence is clear. Urgent surgery plus radiotherapy is better than radiotherapy alone. It keeps people walking, which is a massive quality of life benefit.
We also need to anchor the radiosensitivity contrast.
Right. Lymphoma, breast, lung, prostate, they tend to be highly radiosensitive. On the other hand, GI adenocarcinoma, melanoma, thyroid, renal cell carcinoma, often radioresistant. So surgery plays a much bigger role there.
And what about primary tumors?
The quick marker is age and location. In patients under 18, they're usually benign and in the posterior elements. In patients over 18, they're over 80% malignant and usually in the vertebral body.
Okay, let's talk infections of the spine.
This is a challenging diagnosis, but the key radiological contrast is critical. It's the anatomical difference between the two main types.
What's the marker?
Pyogenic vertebral osteomyelitis, caused by bacteria like Staph aureus, almost always involves the disc. The bacteria love that avascular disc space.
And the contrast?
The contrast is with granulomatous infections, mainly tuberculosis or Pott's disease. TB typically does not involve the disc space, at least not initially. It attacks the vertebral body itself, causing collapse. So if you see the disc is spared on the scan, you have to think TB.
And a final word on epidural abscess.
A surgical catastrophe. An emergency. It demands immediate decompression and drainage because the patient can deteriorate incredibly fast from cord compression.
Let's move to deformity, inflammation, and developmental issues. Rheumatoid arthritis.
Yes. And we have to focus on its dangerous effects on the cervical spine. The key pathology is atlantoaxial subluxation, or AAS, instability between C1 and C2.
And the mortality marker there is sobering.
It is. 50% of RA patients who get myelopathy at this level may die within 1 year. This is not a benign condition.
So what are the critical measurements that justify surgery?
The critical measurement is the posterior atlantodental interval, or PADI. That's the space available for the cord behind the dens. Surgery is often indicated if the PADI is 14 millimeters or less. Below that, the cord is dangerously compressed.
And ankylosing spondylitis.
The spine becomes a single, rigid, brittle, long bone. So even minor trauma can cause a catastrophic fracture. You have to have a very high index of suspicion.
And for that severe chin-on-chest deformity.
That requires a closing wedge osteotomy, usually at the cervicothoracic junction, to bend the spine backward and restore their horizontal gaze. It's a life-changing operation.
Okay, scoliosis, Cobb angle of 10 degrees or more.
Yeah.
Let's differentiate based on age.
The cutoff is 8 years old. Early onset scoliosis, before age 8, is potentially life-threatening. The lungs don't develop properly if the chest cavity is restricted. You can get cor pulmonale and premature death.
Whereas late onset or adolescent scoliosis has a normal life expectancy.
It does. So management is different. Curves less than 25 degrees, you monitor. Curves 20 to 29 in a growing child, you might brace. But the key bracing marker is that its goal is to prevent progression, not to permanently correct the curve.
And when do you operate?
When the curve progresses beyond 40 degrees or there's significant truncal imbalance. And to make it safe, we rely on continuous spinal cord monitoring throughout the surgery, SSPs and MEPs.
And Sherman's kyphosis.
The rigid adolescent hunchback. Surgery is usually indicated for a progressive deformity that's greater than 70 degrees.
Okay, a few developmental abnormalities to finish this section.
Spina bifida, which is failure of the vertebral arch to fuse, and then Arnold-Chiari malformation, where the cerebellum extends through the foramen magnum. This is strongly associated with syringomyelia, a fluid cavity in the cord, and then often scoliosis.
And if a patient has that triad Chiari, a syrinx, and scoliosis, there's a mandatory management strategy.
There is. You cannot just fix the scoliosis first. The rule is simple. You have to treat the pressure inside the cord first. So the posterior cranial fossa decompression is performed first to relieve the Chiari malformation and treat the syrinx. The scoliosis correction only happens later once the CNS pressure is resolved.
Okay, we spent all this time discussing the absolute apex of modern spinal care. But the final section of this chapter is a really profound and necessary reality check.
It's an essential discussion. It bridges the technical skill with our ethical responsibility, and the text highlights two massive barriers to true global spine care. The first is just the staggering cost.
The cost marker is striking. An MRI is routine in London or New York. But globally, a single private scan costing, say, $500 US is multiple months of income for billions of people.
And if you can't even get the diagnostic tool, then the high-cost treatment, the $10,000 titanium instrumentation, the disposable instruments, it's functionally impossible. They just cannot follow the algorithms that we've been talking about.
And the second barrier is the profound lack of trained surgeons.
Yeah. In high-income countries, we have subspecialized spine surgeons, but the global map in the book shows areas where there might be one orthopedic surgeon for 1 million people.
1 for 1,000,000.
1 for 1 million. So specializing in just the spine is an impractical luxury. These surgeons have to be generalists.
And this scarcity forces innovation. It leads to that low-tech innovation marker in the book, the case study of necessity.
Yes, the vignette of the C23 fracture dislocation in a low-income country. In a high-income setting, you'd use fluoroscopic guided C2 pedicle screws. But without that tech, the surgeon opted for a classic low-risk approach, wiring in the arch of C1 to the spinous process of C2 with stainless steel wire and bone graft.
And what's the analysis we have to draw from that?
That true surgical expertise isn't about having the latest gear. It's about dedication to the patient and mastering fundamental principles. The surgeon relied on history, exam, and a stable, effective technique based on pure anatomical knowledge.
Offering the best available treatment under the circumstances.
Exactly. That C1, C2 wiring was safe, it was stable, and it achieved fusion. A far superior outcome to leaving the instability untreated just because the titanium cage wasn't there. It forces us to ask what the minimum effective intervention really is.
That was an expansive and complex deep dive. We've covered the full spectrum, from the 6-week resolving LBP to the 24-hour urgency of CES and the ethical weight of global access.
So let's reinforce those key conceptual markers. First, master UMN versus LMN. Spasticity and hyperreflexia, the circuit breaker on N, versus flaccidity and hyperreflexia, the worn wire broken.
Second, the anatomical cutoff for safety. The spinal cord terminates at L1.
Third, the critical stability threshold for rheumatoid arthritis. That PADI of 14 millimeters or less often indicates surgery.
Fourth, spinal infection. Pyogenic almost always involves the disc. Granulomatous, like TB, typically spares it.
And finally, the life and death importance of the Cauda-Equina classification, CESI incomplete versus CESR retention. Both need urgent decompression, ideally within 24 hours.
We've anchored the technical pinnacle of spinal care from Baily and Love. But if we connect this to that staggering disparity in global surgical access, the millions of people per surgeon, it forces a difficult question. The real challenge for the next generation of global surgical leaders isn't just mastering the high-tech, resource-intensive operations, but rather determining and validating the minimum effective and safe intervention that provides sustainable, functional outcomes for the maximum number of people worldwide.
And that is the ultimate ethical application of surgical knowledge. It moves beyond just the operating theater to address global health equity, something for you to ponder as you continue to deepen your own reading of the source material.